So we're going to shift gears a little and talk about immunotherapy. I thought usually I give the end talk about newer therapies that are coming up, but we have a great speaker to do that this year. So I thought I'd talk about where immuno-oncology is going and begin to introduce you into the many facets of immuno-oncology and where targeted therapies present themselves as opportune collaborators, and go from there. I'm going to apologize because some of the slides that you're going to see here are going to be in the slides for the speakers that come forward. Dr. Ambaka is going to talk about oncolytic therapies, and Dr. Pasta is going to talk about newer checkpoint inhibitors, and so I'll remain small when I talk about those. So I was at Whistler listening to Dr. Axel Hochschild talk about his immunotherapy talk, and he began with this slide, and I loved it. And he said, well, the more conflicts of interest for the speaker, and these are mine, the more balanced the talk. And what it showed me was really the amount of skin in the game that pharmaceutical companies now have for our care of our patients. About 6 years ago, when I put this slide up, there were only about 3 names here. And now you can see the science is exploding. The partners that are ready to come and help us to answer these questions don't just lie in the surgical oncologists that we have here today, don't just lie in the medical oncologists or the PhDs, but the help is coming from all sides, and pharma's been a great help with us to do this. So Dr. Carvajal told you that this would show up, so here it is. These are the trademarks common to cancer cells when I was a fellow in training at USC. And most recently updated in 2011, they've doubled, and there's more and more. We talked a little bit about angiogenesis and how angiogenesis affects the immune system and targeted therapies. But what we'll talk about today is the immune system, how tumors avoid immune destruction, and how tumors promote inflammation that allows them to avoid our own body's attack to them. And we just heard about genome instability and mutation. That's the whole area of chromosomal change and targeted therapies. So one of my patients who's here today gave me this. And this is just really a great evidence of what we're doing. Reprogramming our own T cells to be super cells to go after the melanoma and other tumors. So these are the drugs that are in development, and some that I will talk about. The anti-CTLA-4 drugs like Ipilimumab, the anti-PD-1 drugs, and the anti-PD-L1 drugs. These are the drugs you hear about at every meeting that are coming forward in multiple different tumors and in melanoma. These are the things that you get from your stockbroker telling you that these drugs are super and coming forward. But how do they really work? And it's difficult to believe that we have an immune system that works well to clear a bacterial infection or a viral infection, but can't clear something foreign similar to a virus like our tumors. So let me just show you how one of these works. Ipilimumab is an anti-CTLA-4 therapy, and it augments T cell activation and proliferation. How does it do that? Well, in our bodies, we have our police cells that are out there, these antigen-presenting cells, and they bring a part of a tumor to our T cell, and they show it, and there's a secondary connection that you need to turn on this immune system, a second on switch. And if you don't have this, you don't have what we want, which is T cell activation. And when I talk about this, I say, well, this is like a policeman bringing a part of an escaped convict's clothing and giving it to the bloodhound. And this is the bloodhound that gets riled up and goes after the tumor. Well, in a normal system, if your T cells remained activated for a long, long time, I'd have psoriasis, someone else would have ulcerative colitis. We'd have our immune system attacking our own bodies. So it's not what we want when everything is okay, but it's what we want when we're in a battle, in a war against the tumor. So normally, our bodies make something like CTLA-4 that comes out of the T cell, and it has a higher affinity for this second interaction, but unfortunately, it's a shutoff. It doesn't turn on and activate the T cell, it turns it off, it inhibits it. It puts the brake on this T cell, per se. And what we've been able to do in our laboratories, so the laboratory of Jim Allison at Memorial and now MD Anderson, et cetera, is make blockers here. That even though the CTLA-4 is expressed, even though that it's out there, if we block it, it can never be engaged, and our immune system can never be inhibited. So here's what we were just talking about, blocking CTLA-4 with an anti-CTLA-4 antibody. We talked about the dendritic cell, the antigen-presenting cell, and the T cell. And we said that this is like the bloodhound. Well, once that bloodhound gets activated, there's all these different things, cytokines, inflammatory things that go on, and then this activated T cell goes out into the microenvironment, gets sent out to find the offending agent, to find the escaped prisoner, the convict, and that's the tumor cell. And when that happens, the tumor cell itself has found ways to express these proteins on its cell surface that do the same thing that CTLA-4 does, per se. It inhibits the T cell. And that's PD-L1 and PD-L2, but PD-L1 mostly what we talk about. And that, again, makes our immune system incompetent, unable to truly attack and get rid of and eliminate the tumor cell. So what we've done again is made these antibodies that block this interaction that is negative, 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 inhibitory. And those are the new drugs that are out there that we've talked about. Keytruda, Opdivo, the MEDI4736s, the MPDL3280s. So you'll be seeing this, but so these are inhibitory receptors. We talked about CTLA-4 and PD-1, but through work in laboratories, we found that LAG3 and VISTA, and these are all inhibitory receptors on T cells that we can block. So by making blocking antibodies, we can work to take care of that. And again, our T cells have on switches, separate on switches. And through making antibodies that do the opposite, instead of blocking and inhibiting something, they attach and activate the T cell, we can get a better immune response. And Dr. Pastel will come up and talk to us about some of these. And these are drugs that are currently in our clinics and are looking forward and are looking to give us the answers, not only as single agents, but in combinatorial. So what do we talk about? Well, CTLA-4 is the brake on the T cell, and by putting something so we can't break that T cell, we can have an immune response that's adequate. And again, we're looking at ways to take that immune response and move it to the right area and to make it better. And that's looking at vaccines to hopefully improve that response, bring the T cells to the right place, or adding. But let's go back and talk about why. This was one of the slides at our second symposium, and this shows you what we achieved with Ipilimumab. Standard, these are survival curves, and what you need to know is it just tells you what percentage of patients are doing well and have not succumbed to their disease at a point of 1 year and 2 years. Well, when the data came out for Ipilimumab, it was so amazing that we could improve the lives of patients and improve survival by 20% at 1 year and an extra 10% at 2 years. And more than that, we looked and said, there might be a tail of the curve, that people who are doing well at a certain point may have long-term benefit, long-term survival. Okay, yes, we did palliate. Yes, we gave you more, but this more is an extension. And wonderfully, this is the data that was just presented at the end of 2013, beginning of 2014, by a speaker at our third symposium, Dr. Hody, that showed not only was this immunotherapy good at improving early survival, but if you made it to 3 years, here's a plateau, and at 10 years, you're looking at 20% of patients doing well and still still benefiting from therapy. But this is not enough. What we want to do is be able to take these numbers and take this curve and move it up, move it up, move it up, move it up. So gradually we can say, well, at this time, it's not 20%, it's 40%. Or gradually we move it up and we say at this time, it's not X, it's X plus 20 and X plus 30, and get it towards what we all want, which is 100%. But so I bring you back to this to look at what we achieved with ipilimumab, and then move you forward and look at what we're doing with anti-PD-1 antibodies. And what we did, what you remember is a number that went from 25% to 40%, but look at this 1-year survival, now 69%. And this was just recently presented by Anthony Rebus at ASCO. And you can see here that as you look at this, what we call the tail of the curve, the immunotherapies are showing that, again, this is months, and we're at 30, but this will be updated again. But at 120, we're hoping that this tail here remains higher than 40. So we're achieving great things. And these have all come through the clinical trial system and the ability to bring drugs to patients and accrue. Dr. Postow and others have been involved in combinatorial studies, and this is a combination of a PD-1 and anti-CTLA-4. And what we've seen is, we just look at the whole group, that the 1 year now, in this smaller subset of patients, the 1 year begins to go higher. And this is early data, and there's a big trial that accrued and hopefully will be presented soon. But if you look at the numbers at 1 year, we're not talking about 20, 25, 45, 69. We're now taking those numbers higher. And we're looking at 1 year, 85%. And if you remember, the 2 year was somewhere around 15, and now this 2 year is about 80%. And if you look and you squint and you work hard and you think about it, hopefully we'll look at 120 months out, and that number will be multiples greater. So how are we doing that? Not only are we getting long-term benefit, but here is another waterfall plot. I mean, it's tough to have you wonderful people here and then teach you statistics and numbers, because I hated statistics. But you can see now with immune therapy, the idea that minimal number of patients really do well and have a benefit is being changed. This is about 72% of patients having some control and shrinkage. And those people who benefit continue to do well. And this is the point, that when you look at these times, weeks, this is a year, when you talk about targeted therapies, you say, well, half of the patients are off at, half of the patients that respond are done at 6 months. But when you're looking here, the majority of patients, 90%, are having control at 1 year and moving forward. And this is just light years better than what chemotherapy has given us. And this is improving what targeted therapy has given us. But so now you say, well, okay, what does that mean? What do we do with chemotherapy? What do we do with these targeted agents? And what we've learned in our clinic and the clinics of Dr. Ambaka, Dr. Ferries, Dr. Carvajal, Dr. Postow is that the combination or even the sequencing of immunotherapies with these targeted therapies, with chemotherapy, is giving better outcomes than just each one of these alone. And by sequencing, I mean you don't have to throw them all in together, but right after bringing these other therapies. So what are we getting? This was Dr. Carvajal's talk. Good early response with shrinkage, but as the time course goes out, unfortunately, the response doesn't last. With anti-CTLA-4 therapy, it took some time, but durable long-term, this is that tail of the curve. And with PD-1, a higher hopeful tail of the curve, and this data will be hopefully presented at ASCO at the beginning of the month. And then with combination immunotherapy, almost better. And it's interesting, as we come to the end of May, which is supposed to be Melanoma Awareness Month, it's also Brain Tumor Awareness Month, it's also Clinical Trial Awareness Month, and then next month is Immunotherapy Month. It's interesting how all of this is just bleeding into the care of all patients with all different types of solid and liquid tumors, so lymphoma, lung cancer, etc. And as we found these therapies, I'm just going to show you one. This is data that was just presented at AACR last month of, well, what's the right first therapy? We're going to answer that, and how do we sequence? And this was a trial looking at ipilimumab as a first therapy versus getting pembrolizumab, which is one of the anti-CTLA-4 antibodies. And what it showed is not only was getting the anti-PD-1 better for progression-free survival, the amount of time that you continue to respond to therapy, but getting it anti-PD-1 therapy in the first line was better than just getting ipilimumab in the first line. So we're answering those questions. So better than anti-CTLA-4. But we're not, don't get me wrong, we're not saying that we're now done with one of these drugs. We're now looking to figure out how we can improve each drug, not just improve them as far as response rates, because that's what everyone says. I want this to work, I want this to work well, and I want it to give me maximum. And I hear this combo is better than that combo, and I hear that this drug is better than that drug. The answer is trying to find out how to put them all together, have less toxicity, have better response, and be able to get our patients to see all of these therapies in a way where we can find the one that benefits each patient the best, and more on that later. So this was data looking at an old drug, GM-CSF, that stimulates the white blood cells with ipilimumab. What we found, and this is a trial that was chaired by Steve Hody again, and what we found is looking at them, when you compared them, the progression-free survival, the amount of time that you continued to have benefit or response was the same, but there was something in the combination that helped patients do better and survive longer. So we're looking at not just what to do with anti-PD-1 therapies, but what to do with anti-CTLA-4, how to bring it back and make it better. And this combo showed decreased incidence of toxicities, improved responses, and we move forward. Again, with permission from Dr. Palstow and others, this is the data of anti-CTLA-4 and anti-PD-1 therapy. I showed you a little bit about it, but what we saw here was higher response rates and benefits. What we saw here was the possibility of better long-term survival with combination. And what we saw here was something that I'll be talking about later, is getting response rates that are high, not just in patients who are PD-L1 positive, high PD-L1 staining, which we're trying to look as a marker, as an ability for us to say, who does well with PD-1 therapy? Is it the people whose tumors stain high for PD-L1 or not? But the idea that this combination may have obviated the need to even look at that, where even the negatives responded to the same percentage as the PD-L1 positives. So, and these are the evidence of response from here. You can see that lots of shrinkage in the majority of patients. These are spider plots that show that there were a high proportion of patients who had more than 80% of their tumor go away with this combination therapy. Let's move on. So what happened? We saw high response rates, good durable response and shrinkage. But there was some questions about toxicity. There was some questions about availability, or whether this is a combination that is good for all, or how do we find the right patients. But again, the discussion came that every patient that came through the door said, is this the right combination? Is this the combination going forward? Well, the good news is that other combinations are starting to show the same type of benefit. And I'm just going to show a little bit about this. This is the T-VEC. Dr. Ambaka is going to spend some time telling you about oncolytic therapy of injectable immunotherapies with ipilimumab. And here, we're seeing improved response rates. Just with this oncolytic therapy with ipilimumab, we're looking at overall response rates of 56%, where traditionally, just with ipilimumab, even the biggest supporter will say that the response rates with ipilimumab are around 15%. So combinations with multiple immunotherapies going forward. Dr. Ferries is going to talk to us about adoptive cell therapy and what it is and how we do it and where we go, so I won't spend the time. But what I will tell you is, and these are some data that come from the NIH, where they looked at the patients that they treated with these adoptive cell therapies, and they saw that these patients had a good survival. Look at this tail of the curve, which is pretty good. But if you'd seen a prior checkpoint inhibitor, they did pretty much better. So the question becomes now, can we combine these therapies, or do we need to just sequence them to go forward? No. Thank you. All right, but the key is to, get on top of these immune cells and take them to the right place, and that's to the tumor. And that's why I like this cartoon so much. I'm going to talk to you a little bit about a new type of immunotherapy that's available in clinics, and this is IMC-GP100. The data was just presented, some of the early data. Antibodies and antibody drug conjugates are antibodies that target the tumor. Drug conjugates have some chemotherapeutic attached. Dr. Ferries will talk to you about CAR T cells, but this is a bispecific. This is what I call a matchmaker antibody. It targets one side and targets the other and brings two things together. It's sort of like those of you who are Jewish will know that it's a matchmaker. It says, you, T cell, come here. You, tumor, get here and start to work, where we can drive the immune system directly to where we want it to go. And here's a cartoon of that. Oof. Tough crowd. So anyway, so the cancer cell expresses a protein, and the T cell expresses CD3. This antibody goes and binds to that protein, and also then brings the T cell close. The T cell binds, and it has its ability to take its acid, its lytic granules, in a perfectly optimized synapse and a perfectly optimized sort of kiss. And what we want is for that T cell to release all of that and kill the cancer cell. And that's an electron micrograph of it. And this is exactly what happens. All right. And so this is some of the initial data that's been presented with this drug. What's so interesting is we're seeing good responses, durable, but we're also seeing responses in ocular melanomas, which are traditionally not responsive to immunotherapy, and traditionally that we haven't had a lot of therapies for them. So it's now going forward in trials. Now, what about the other things? If I said to you that there's PD-1, there's anti-CTLA-4, there's this, there's that, how do you find the right person for the right drug, the right person for the right therapy? And this is what's the new thing. This is why I want your blood when you come in, and I take all of the 18 tubes from you and you and you and you. And then you get dizzy when you stand up to the room. I want your blood and your tissue. You'll see almost the same haircut and the same eyes. It's a handsome job. It just happened like that. But the blood and the tissue is very important because we're looking at it and we're staining that tissue, we're staining that tumor tissue in order to figure out, well, what does PD-L1 staining in your tumor tell us? Does that mean you're going to respond better to this therapy? Does that mean you're not going to? Does that mean I got to give you something else before or take you to a targeted therapy? And so this is what was shown just with the Keytruda, the pembrolizumab compound, that those positives had a higher response rate. And so we're looking at that and what that means going forward, not just with a single agent, but with combination therapies. What we're also looking at is tumor. We biopsy. I'm going to biopsy your tumor, treat you, biopsy again. Try to figure out what happens when we give these drugs. If PD-L1 staining is like this and your T cells are like this, what do we need to get? Do we need to get you like this and this? Can I do a biopsy after just 2 doses, which is 4 weeks, and know if you're going to respond, you're going to benefit, or we can ditch it and go to something else if I can tell you you're not, or we can add another drug, or we can take you to targeted therapy. So these are the things that we're doing now, aside from just finding the right drug, but finding the right drug for the right person. And this is from John Powderly, who's in Carolina Bio-Oncology Institute. This is a patient of his with renal cell carcinoma. They biopsied him initially. You see low PD-L1, and you see the CD8 cells all around, but light. And on therapy, this is what happened. In that synapse I showed you, it's staining higher for PD-L1, and the CD8 T cells are coming forward. And when you look at it, the tumor is all dead, and it's just immune cells going forward. So that became this, that this patient's responding and doing well for an extended period of time. These look familiar. But also what we found, just not looking at tissue, but looking at blood for gene markers, we saw that these patients that are responding, and this is a Nature paper, Roy Herbst is the primary author on, from a drug that we've been working on in the clinic. We saw that these, the expression for all of these inflammatory markers went up. So I might not need your tissue. I may just need your blood, and I can just run this and in a week know what's happening in those areas where you have tumor. What about biomarkers? I talked about PD-L1 staining and what it means for those patients that respond. But we can stain for PD-L2. You'll hear about IDO from Dr. Postow. But what if we can just stain like this and know, but then take those and combine them and have a higher biomarker? I can look at it and say, hey, Joe, I'm sorry if there's someone here named Joe. Hey, Joe, PD-L1 is positive, your B7-H3 is positive, you're going to have an 80% response rate. And that's amazing, because we talk initially about drugs that have a 10% response rate, or a 30%, or a 40%. And when patients hear me talk about statistics, I say, statistics are, this is where I need the singers. The statistics is like a Jesse Jackson thing. It's needed for education, population, sanitation, if you're going to do a budget. But for one person, the statistics don't make sense. If I say you have a 5% chance of responding and you respond, wow. If I say you have a 95% chance of responding and you don't respond, you're going to come after me. But these are the ways where we're going to know what the right therapy is. And this is how we're going to translate it. Here are gene signatures that are going forward, and this is work done. All of these slides I showed you are work done at Genentech. By the way, this program is led by a gentleman who is a medical oncologist who used to see melanoma at Stanford. So we've infiltrated into big pharma. And then what about something easier? And this is presented by Rich Joseph. And it looked at how patients responded to pembrolizumab and survival curves. And they took many different prognostic factors, and they found baseline tumor size. If you took and you just measured, and you found out how big things were, baseline tumor size can tell you, and it was the strongest predictor for survival benefit. So this is what the deep dive into the data is what's so interesting now in immunotherapy. This again comes from Dr. Postow's group, because that's where it's heading. But looking at just with Ipilimumab and its 10–15% response rate, how do we find out who did well? And they looked at their patients had long-term survival and found a gene signature that is now going prospectively in clinical trials. So you come in, give me your blood, I'll look at your gene signature. Does it match this gene signature? You're going to do well, you need this drug. If not, let's go somewhere else. They looked at the mutational level in the tumors, and the high mutational level patients were the ones that responded. So come in, give me some tumor tissue, give me some blood, I'll run one of these. Don't ask me how you read it. This is a mutational map. And I'll tell you if you're going to do better or not. And then let's take this to the harder things. The brain metastases that plague patients with melanoma. But I will say, and I've been saying this for a long time, that this is not just a melanoma problem now. Now as we're doing better, patients are doing better longer, and unfortunately the cancer is finding places to hide. And this is one place. This is a patient with a brain metastasis not treated by radiation. So for the radiation oncologists out there, sorry, the neurosurgeons, this was not a surgical resection. This is a patient treated with anti-CTLA-4 therapy, Ipilimumab, with resolution of the brain metastases. This is a patient treated with anti-PD-1 therapy. This was presented by Rick Keffert at ASCO last year with resolution of the brain metastases. And this is a shameless plug for a clinical trial that we have and we're running at multiple places with the combination. That combination that looks so promising for melanoma didn't allow patients with live brain metastases, and this one does. Trying to bring those benefits to the later stage patients, the patients who really need good, quick responses. But also, what about earlier? When our surgeons take out tumor and there's an adjuvant, there's no evidence of distant disease, how can we prevent this from happening? How can we prevent these tumors from coming back in the metastatic setting? And we've looked at Ipilimumab in this situation. We're seeing that it does help prevent relapse. This is a relapse-free survival curve. Now, does it help in overall survival? Stay tuned, because by the end of this year, we may have a readout on that. But PD-1 in the adjuvant is coming in clinical trials now, too. It's less toxic. It showed that it's better in the metastatic setting. What about in the adjuvant setting? And these trials are coming forward. So as I come to the end, I would like to stress that Immuno-Oncology is responsible for major strides in care for patients with melanoma. But we've known that the immune system is responsible for better outcomes for a long time in multiple solid tumors. And 6 years ago, when we started these talks, I could never talk about these solid tumors because these solid tumors didn't come to us at Angeles or at Memorial for immuno trials. And now we have these trials for patients with every type of solid tumor. And now the people who are making these drugs are dedicated to the care of the patients with metastatic melanoma, because this is how these drugs have come forward for everyone. So that's before just BRAF and Ipi. That's like the first year when we started this. This is what I used to look like. This was Carvajal. Spent too much time in the office and not in the gym, but this is now. And we have all of these therapies. And not only that, one of the greatest things is every year when we look at the list of people to invite, it's extremely difficult because we only have a couple of chairs. And every year it becomes greater and greater, the number of investigators who step forward to take care of patients. So with that, there are no limits. We're going to figure out the answer about biomarkers, which tumors benefit, how to combine. Cost is not something we talk about. We're going to improve toxicity, and we're going to, at the end of the day, help patients. So I'd like to end by acknowledging that and thanking you for your time.